Hello, everybody, and welcome to Airway Circle Radio. My name is Nicole Goldfarb, and I'm the host of this show called Airway Answers, Expanding Your Breadth of Knowledge. And I'm a speech language pathologist and certified orofacial myologist. And today I have the lucky day of hosting this show with three amazing physical therapists, all who have advanced training in airway, TMJ disorders, and myofunctional issues as well. So we have Dr. Dave Evans, Dr. Cale Goldfarb, and Dr. Randy Esquibel here. And I'm just going to do a quick summary of their bios because honestly, these people are amazing. And there is so much information in their bios. So I'm going to start out with Dr. Dave Evans, and he is a board certified orthopedic specialist. And actually all three of them are, and that is a designation that less than 3% of physical therapists in the country have. So that is amazing. Dr. Evans is a doctor of physical therapy. He's a director of one of the clinics at Water and Sports Physical Therapy in San Diego, California. And he has a strong background in orthopedic and manual physical therapy with advanced training in a variety of musculoskeletal dysfunctions. He's taken multiple classes in cervical, thoracic, and lumbar spines, as well as lumbar pelvic complex, extremity integration. He's certified in myofascial manipulation. He has training in myofunctional disorders and training in the interrelationship of form and function of the musculoskeletal system and the TMJ. He also has advanced training in PRI, which we're going to talk about today, Postural Restoration Institute, Selective Functional Movement Assessment, and Dynamic Neuromuscular Stabilization. I can barely say all these words. All right. And Dr. Evans believes that a good physical therapist needs to have advanced knowledge of anatomy and biomechanics to really understand the complexities of the human body. And also that a physical therapist should treat not just pain, but the underlying cause of pain and the dysfunctional movement patterns and dysfunctions that are causing the pain. And that's one of the reasons he is so amazing, is because he understands that connection of whole body and airway to other issues that patients may be presenting with. We also have Dr. Randy Esquibel. Hello, Dr. Randy. She's also a doctor of physical therapy, board certified orthopedic clinical specialist, manual therapy certified. Dr. Randy also has advanced training in PRI, Postural Restoration Institute, and is actually certified in PRI integration for baseball, postural respiration, pelvis restoration, cervical revolution, and myokinematic restoration, all PRI coursework, which is absolutely amazing, completely ties into whole body posture, breathing, and airway. She is also certified in dynamic neuromuscular stabilization. She's a director of one of the clinics for Water and Sports Physical Therapy. She's certified in myofascial manipulation, about 10 other things within that I can't even read, certified in blood flow restriction. She also has some training in myofunctional therapy as well, understanding the connection of oral rest posture and functioning to airway breathing. And one other amazing thing about Randy is she has a passion for understanding human movement and function and its relationship to breathing mechanics and all aspects of physical training and human function. That whole underlying component to whole body function. And then we have Dr. Cale Goldfarb, and he is also board certified orthopedic clinical specialist with a postgraduate doctoral degree in orthopedics and manual therapy. He was the former head physical therapist for the San Diego Padres, also former adjunct professor at San Diego State University doctoral program for physical therapy. He's a national certified strength and conditioning specialist, has advanced work in orthopedic manual therapy. Like all of these physical therapists here with me today, all that hands-on approach is so important for the patients that we work with. He's also certified in SFMA, Select Functional Movement Assessment, dynamic. He also has coursework in dynamic neuromuscular stabilization and also coursework in PRI, again, Postural Restoration Institute. And interestingly, he has also worked with NASA and UCSD to provide information on how to help astronauts in preventing spinal pathologies after returning back to Earth, which is kind of a cool, interesting thing. He also lectures and teaches to surgeons on the SI joint and has co-authored chapters and books in orthopedic and sports performance. So there's way more about all three of you guys that I had to leave out. But as I read that, I'm like, wow, you guys are amazing geniuses. So it's just really interesting. Every time I talk to the three of you, I'm like feeling like I'm a sponge, like tell me everything, because the whole body is so connected. And now working with the three of you and treating the myofunctional therapy patients, I think, wow, the treatment they're getting is so much better when we have this team approach. So I want to ask, I'll start asking Randy about the PRI, Postural Restoration Institute approach, which comes up at a lot of the coursework now, talking about airway. And can you just explain what PRI is, how you use it, what does it mean? Because I think it's a name a lot of therapists are going to be hearing more and more.
Yeah, absolutely. So it's a combination of respiration, neurology, biomechanics. I feel like they do a really good job of explaining the asymmetries that our bodies have, just anatomy wise, when heart on the left, different lobes on the right, that the muscles that attach to our spine, specifically the diaphragm, are different from the right side and the left side, and how that can bias us into certain positions, and end up creating a little bit of compensation. So they basically have tons of techniques where you're utilizing muscles to help reposition the body to find symmetry, not to necessarily be there because we're not symmetrical, but to find the ability to move back in and out of that asymmetry so that we're reciprocating well. So everything they do is around balancing that muscle activity around the sacrum, the pelvis, the sternum, that kind of upper trunk thorax, and the sphenoid, which is bone in the center of your head. They're using all of the multiple systems of the human body for appropriate integrated asymmetrical function, which is a lot of big words. But again, just comes back down to respecting that our anatomy is not symmetrical and making sure that we're using air and finding the balance between air and muscle tension to make sure we're making those neurological changes or staying in a happy neurological state.
And what do you mean air and muscular tension?
So bringing air in to our lungs creates inner abdominal pressurization throughout our lower thorax. So a lot of times when we're talking and cueing with patients, we'll say, breathe in down to the belly or the back or that full 360. And we're not really pulling air into that space. We're pulling air into our lungs, making sure that we're filling that lung and that full mediastinum space with air so that we can then pressurize their trunk, which is truly how we stabilize that foundation that our extremities and head and neck are attached to. And the either ability to do that well, normal, or not so well would create different tension within the body. Or say we get stuck in one of those patterns and we're stuck in our asymmetry instead of reciprocating through it, we can start to have muscles turn on. So we end up with tone in certain tissues that may feel tight, but they're really just on and facilitated because of the position we're in, and gravity's always there. Gravity's always pulling on us. So it's really techniques to help you figure out how to pressurize well and manage that pressure throughout our entire systems.
What about for people who are really not good at diaphragmatic breathing? Is that something you teach in the PRI approach? Or I don't know, maybe Dr. Dave Evans could talk about that, because I know I have a problem with that where I feel like it's hard to get airflow really low. So how does that intertwine with Postural Restoration Institute approaches that you use?
Yeah, absolutely.
Go ahead, Dave.
That's a good question, because a lot of times what we find is that patients that have the classic bad posture of the forward head, maybe the slouched shoulders, a lot of our patients that we see, we find that they cannot get out of this certain position because they are not getting that intra-abdominal pressurization that Randy had mentioned, because they're not diaphragmatic breathing correctly. And a lot of times what we find is that they'll instead use their SCMs, their scalenes to breathe. They're using their intercostals, their pecs, all of these accessory breathing muscles. So the problem is that it facilitates even more of this upper chest bad breathing patterns, which causes all of this fascial tightness and all of these abnormal movement patterns. So certainly when we're talking about a PRI approach to change pressurization, to change how a body is accepting air, that's one of the fundamental things. We want to start right off the bat with teaching someone how to do a proper diaphragmatic breath. And I feel like a lot of patients, a lot of even medical professionals sometimes think that diaphragmatic breathing is belly breathing. And it's not really belly breathing, because if we're just having our belly come forward, we're not utilizing the ribs and the full diaphragmatic connections throughout the back part of the ribs. So some of the very first things that we'll do is we'll teach them how to do that. You can even do that just real easily and quickly in a chair. Like as we're sitting here, you can put your hands kind of on the lower ribs, kind of surrounding the outside and the back of them, and just focus on easily breathing into your hands and then out. Nothing too forced. And a lot of times this works really well. And I've seen Randy use this approach a lot, where you just get into basically a fetal position, or like a modified child's pose, basically. And you just work on breathing into that back portion there. Because if we can start getting those ribs and diaphragm to work the way that we want to, we start training the pattern in our head, in our brain, to start using those muscles. And we start taking away a lot of tension, tightness, and breathing from the upper chest and all these different compensations.
That's really interesting too, because I feel like a lot of people, if they're not integrating a team approach, they think like, oh, fix the airway, maybe structurally, and the person's fine. But what you're really showing is you have to rehabilitate the breathing patterns, right, Dr. Dave? Like it doesn't just naturally like, oh, you fix the airway and now you're a diaphragmatic breather. You actually probably have to teach that, right?
Exactly. Because if you've had someone that has done a certain activity for forever, they have these inherent patterns and these bad habits that we now got to break down. And we have to neurologically retrain them how to do that.
And Dr. Randy,
go ahead. I think one of the biggest common things I see too is when people think of posture, kind of again like the bad terminology of belly breathing. It can tell the brain, to do something so specific, whereas we might have meant well, but it's not exactly what we wanted to happen. And I see all the time patients go, oh yeah, right, I gotta sit up straight and work on my posture. And they sit up straight and throw their shoulders back, and almost always they've then tipped their lower rib cage and flared that forward. And that position automatically sets up that diaphragm muscle at a disadvantage. So it's already on, it's out, and it's flattened a little bit. So it's doing part of its activation when we're just hanging out, instead of relaxing and resting all the way into a neutral state to be able to be engaged again. So I think it's a very common thing that we see, and that's step one. We just have to teach them how to get their ribs back into a position where that muscle can fully relax, so that we can get a full and appropriate contraction out of it. It's so easy for that diaphragm to fall into dysfunction. It's got a hard job. It's postural, it's respiratory job. It's got psoas muscles going through it. It's got a whole bunch of other sphincters, esophagus, things going up, obviously, into the upper airway. So it's a challenging job that muscle has. So it's very easy for it to become dysfunctional. But step one is just helping people be aware of getting that control of that anterior rib cage, so that we can use that muscle appropriately and get that expansion through the back.
When I was going to physical therapy and you were working with me on these techniques, I was working with Dr. Dave, and I would just start yawning almost uncontrollably. And it's no doubt this is triggering the parasympathetic nervous system, right? With these techniques.
Absolutely. Absolutely. And that's one of the things that we really want to go ahead and trigger when we think about the parasympathetic versus the sympathetic system, your fight or flight versus your rest and digest. The human body is not designed to be in a constant state of sympathetic overdrive and stress. And you can think about all the stressful situations and thoughts that you have over the course of the day. And a lot of times that leads to more shallow breathing, poor breathing habits. And so really when we're getting a patient into proper breathing techniques through the diaphragmatic breathing postures, then we find that there's actually a downtick in the sympathetic overdrive and an increase in the parasympathetic. And so that leads to a lot of that reduction of muscle tone and tightness. It allows for changes in posture. And one of the big things also is that when you get into the parasympathetic system, there's actually neurological uptick in the really, really deep stabilization muscles, such as your diaphragm, your different core muscles like your transverse abdominis and your pelvic floor muscles, even all the way up to your deep neck flexors of your neck. And so we find that not only does the body sort of have this effect of, oh, I can just sort of relax and I don't have to, be constantly working and stressed so much, but that relaxation, but we're also now getting the good key spinal stability that we need.
So interesting. Like all this makes me start going, okay, posture. We're talking about breathing, diaphragm, parasympathetic, but so many of the airway patients, actually nearly all patients, and it's actually a human condition, even children, we see poor posture. So, Dr. Kale, can you talk about the role of forward head posture and airway and headaches and all that interrelationship?
Sure. So I think that, like you said, Nicole, many of our patients come in with poor posture. And clinically speaking, we all see that our sleep breathing disorder patients are all in an extended position and they end up having this poor postural position, even just from here up, we're talking, right? Obviously, the whole body's connected. Where your head goes, your body follows. But if we were to look at headaches, one of the criteria for sleep apnea is people can have headaches. The question is it a physiologic headache, which it could be just from the process of having sleep apnea, or is there a secondary musculoskeletal component? So headaches can be multiple causes, but the few I want to talk about are a cervicogenic headache. That means cervical, spine, and origin. So we could have patients that come in with bad posture. Maybe that's secondary to they need air, so they're in this position. And they could have headaches from soft tissue, which we'll talk about later with referred pain, or they get headaches that come truly from joints and nerves. So if we break those down, if a patient walks in and they have a headache that runs in the back of their head, this could be, one of the sources could be occiput on C1. So that is, imagine your skull here. What happens at occiput on C1 is just this nodding, right? So if you come all the way back in chin tuck, you come all the way forward. Now, obviously, most of our patients are in this forward head position. So what happens in that position when you have the occiput on C1, there could be a compression at an articular level, or there could be a compression of a nerve. The nerve there is a suboccipital nerve. In some people, anatomically, the suboccipital nerve could feed into the greater and lesser occipital nerves, which run in the back of the head. So if a patient walks in and they have pain in the back of their head, the first thing I'm going to want to look at is occiput on C1. Now let's take the other type of headache. We have patients that come in have headaches around the eye, right? We see this a lot. What could that be coming from? Well, if you go to one level below, you have C1 on C2. Now C1 and C2, this C2 nerve root. Now how would the C2 nerve root, which actually just goes down, how would that cause headaches? Well, this is really interesting. The C2 nerve root, if you pathway up toward the spinal cord and up to the brain, it has the same pathway as cranial nerve number 5, the trigeminal nerve. And as we know, trigeminal nerve has 3 branches, right? So you have your branch, the ophthalmic branch, then your maxillary branch, and your mandibular branch. Well, most of the nociceptors in the trigeminal nerve are in the upper branch, right? So we have the ophthalmic branch. What happens is this afferent message, so there's an irritation at C12, C2 nerve root. This message stimulates the brain, sends an afferent impulse up to the brain, same pathway as the trigeminal nerve. And then what happens is it tricks the brain. Now the brain thinks something's happening at trigeminal nerve because there's an input. And now it thinks something's happening there, so it causes you to feel symptoms into the eye. So when we have somebody who comes in with a headache and they really feel it through here, the first place we're going to look at is C1 on C2. And we notice clinically, and there's research showing this, that when we treat the upper cervical spine, if it's a musculoskeletal cervicogenic headache, we can actually help eliminate these headaches. Now, that's very different from a migraine, right? Migraines are between 4 and 72 hours. Usually there's the aura sensation. Sometimes they have photophobia or sound sensitivities. They have nausea, vomiting. It's a very different type of thing. And we're not as successful when it's a true migraine. Can there be a migraine with a cervicogenic headache component? There could be. So I would want to propose, if we have a sleep breathing disorder patient come in and their major concern is, man, these headaches are really bad, I'd want to rule out the cervicogenic component because, like we said, if the patient is stuck here all day, you're going to get afferent input from those components in the neck that can cause those headaches. If we know that, we can help reduce those headaches to make sure at least we take care of that portion of the patient's symptoms.
And can you explain what is forward head posture, like from, I guess, a head down or however far you want to go, but why is that helping with breathing and why do patients get in that position, Dr. Kale?
So if you were to imagine somebody who needs air, like the CPR position, what do? You actually tilt their head up. You're opening the airway. Mm-hmm. So what we see even children, they come in and they're just in this position. And they're just trying to open airway to get air. So if they have better air, if you think about it this way, your brain works as a primary and secondary communicator of what your body's going to do, right? So you have two choices. You have somebody walks in and they're here like this, right? And the brain says, ow, I don't like this pressure over here. I don't like these muscles tightening. That's one option. The other option is, I need air. I need to breathe. Which one's primary? Breathing is always primary. So no matter what it's causing from a musculoskeletal perspective, it's always going to go primary air. So when we have a kid, and this is, I think, really important to delineate, when we have a kid who comes in who's 8, 9, 10, 12 years old, and the parent's like, well, he's just bad posture, it's just genetic. I would pose to all the therapists out there, or any practitioners, it could be genetic, but what is the gene? What is the genetic component? Is it that it's a structural airway issue that don't get enough air, so they need air? Or is it that because my dad has bad posture, I have bad posture? Well, why does dad have bad posture and mom? Is it because they have an airway issue? So I would at least keep that in mind, that airway is primary, breathing is primary, and the posture could be faulty because of the airway. Because when we have these kids and the parents say, oh, he's really tight and stuck down here. And then we look and we mobilize their spine and check. We're like, there is no tightness. Muscles aren't tight. Joints aren't tight. They have full mobility. They should be able to be here in the correct postural position. But they're not. Why? Now, there are neurological conditions like CP and other higher level neurological conditions that can cause this. But we're talking about the typical kid who just is in a bad postural position. So first, rule out airway. And then if there's not an airway problem, if we get them in the position, and they can breathe regularly and without getting excessive muscular overload, then that patient can be retrained to be there. And it shouldn't take very long. Neuromuscular retraining could happen in a day, maybe 2 weeks. It doesn't take 6 months to retrain muscles. It could be immediate. Depending how you dose the exercise and load the patient with exercises, I've seen patients who are even older, 50, 60 years old, that come in like this. And then within a week to 2 weeks, they're actually more comfortable in a correct postural position than they were in their old postural position. So all these things can be changed, but we have to come from the lens of, is there an airway problem? Because if you fix all this and they have an airway issue, they go right back to here anyway.
I thought that was one of the most kind of interesting things once I started training with Nicole and learning about myo and getting involved with the upper portion, was that, you have all these patients you've worked with forever and you're working on that posture and addressing forward head posture and giving them all the tools you can. And let's look at your ergonomics. Let's change this, let's change that. But it really was all of a sudden oh my gosh, how are we leaving this out? How are we, from the very beginning of my career, the first course I went and took was DNS, and was why did we not learn so much about the diaphragm in school? And like, this is huge. And it's kind of changed everything I've continued to do since. And I'm like, oh, I'm all about breathing and airway, but I was never talking about where the air was coming in. So it's been really eye-opening to make sure you're not leaving that out. And I've had patients come back that I've, treated 5 years ago, and they come back and it's like, well, now I know that I know what I know. We've got to like tackle this actual airway issue and how you're getting air in, whether it's during the day, at night, or both.
Yeah, that was one of my questions actually, is like, now as a physical therapist, now with knowledge of airway and oral rest posture, how has that changed the way you might assess and treat patients? Like, Dr. Dave, how do you feel like maybe the way you assess and treat patients, and any changes you've noticed in your patients? And we all have that patient guilt where we're like, oh my gosh, there's like 50 people that I treated 10 years ago that I totally missed something. We just kind of have to let that go.
Yep.
But let me know, Dr. Dave, what you think.
Yeah, I was going to say that patient guilt is usually the very first thing that pops up. Like, oh man, I saw this person years ago, and oh shoot, now I know what I know, but I didn't back then. But absolutely, because if we break it down to its core function, breathing is one of the things that has to happen for life. So our body, our neurology, our musculoskeletal system, it's going to move around that. So that's really one of the first things that you need to assess. Somebody to go off of Kale's example here with the forward head and the headaches, we need to go ahead and then also assess, well, what's happening lower too? Like, are we not breathing appropriately lower down? Or do we have some fascial connections that are limiting our ability to expand our rib cage down below? Are we having this uptick in, sympathetic system? And before, I used to be like, okay, well, someone's having hip pain. Oh, well, let me just check their hip. Oh, okay, well, maybe you got some weakness. We could go ahead and we could work on that. And now I know, well, just like Randy said, none of that stuff is very, very bare bones basic that you learn in school at the early part of career. But where the heck now was all this, when I really needed to understand, well, no, what's actually happening is their hip pain is because they're not diaphragmatically breathing efficiently and their airway is closed. So what are they doing? Their forward head, their rib cage is flared out, their pelvis is in an anterior tilt. So guess what? Every time they're sitting at work typing on the computer, we're tightening up more, we're compressing the hip joint more. And then guess what? For lunch, they decide to go out and run a few miles because they just got to get out of the office, but they're not ready for it. And that contributes to things. And so it's really changed my outlook on even just the most simple, quote unquote, orthopedic situations, because a lot of it does come back to the airway.
And do you guys feel like you're treating patients better, or you're getting better outcomes, or doing something differently now that you have this understanding of the breathing, or in terms of like airway and the upper like oral muscular component?
Absolutely. Yeah. I feel like, especially even just being able to recognize it's like, once you see it, you can't unsee it. And so even with the mask, it's like, I'll ask people, I'm like, okay, can we take our mask off while we go through our, just some posture segments? And they're like, my mask? Like, I'm here for my foot. Like, well, we need to see everything, and just to get a little small gauge of like what's going on with that kind of head position and jaw position, and the full picture of the patient, and being able to just recognize things that I didn't recognize before, and I have a team for that. Whereas, again, I had a patient come back that had been diagnosed with almost MS and almost this other neurologic disease, and almost had a heart surgery, and almost had a spine surgery, and all these things. And she's gotten better, and ups and downs. And once I learn about airway, she comes back and I'm like, you need a sleep study. She gets CPAP and nothing's wrong. All her pain goes away in like a couple of days too. She's like, love you, but not see you next week because I'm good.
My God, that's amazing.
Yeah, it's those type of scenarios where you're like, I found things that were objective for me to be able to treat, because the body is going to make changes, especially if it's fighting for air for a long time. That compensation gets stronger and stronger. So you'll find things that are very treatable, but I think that it's really helped me understand if we're really getting to the root of that issue, whether it be airway daytime, airway nighttime, are you resting well? All of that information's tremendously changed what I do.
Yeah, and it's funny, like one of the reasons I just think you guys are so great is because it's funny. Randy says someone comes in with a foot injury, and you're like, "Let me see your face," like because it's all connected. So, Randy, if you want to talk about like that deep front line fascia, can you talk about like what is fascia? I know that's kind of a big word. With given like tongue ties, and what is fascia, and how it all relates to movement, posture, breathing.
So it's connective tissue within our body, beneath our skin, around every muscle. I try to explain to people that, muscles, it's kind of like it has its own little sausage casing. And it should glide and slide freely, and also helps distribute some of the force that's produced and put through muscle tissue. So it's not just the muscles taking that load or producing that force. The fascia also helps with that. The deep front line directly communicates with a whole bunch of different lines, reference like anatomy trains, and they'll connect the fascial lines in the muscles. So it's basically saying there's a continuous connection from tongue to the mediastinum, to the diaphragm muscle, to the adductors, the hip flexors, all the way down to the flexors of the toes, and muscle to the foot. So it's connecting those dots and how those tissues can be interrelated. And there's a whole spectrum of someone may potentially fall under like they're more hypermobile and they have a harder time finding this tension in their fascia. On the other end of that spectrum, people can be really stiff and hold a lot more tension in those tissues. Just making sure we're looking at everything from head to toe, and especially that relationship to the tongue. And there's a whole bunch of other connections that'll happen into some of the muscles. Dr. Dave already talked about the anterior neck, the scalenes. There's so many other muscles underneath the neck that, again, we learn about in school, but they're not common in your treatment in outpatient orthopedics. Like I'm not, getting after an omohyoid, and so there's a lot of the other muscles underneath there. But it's now, knowing what we know, important to recognize that the tongue directly connects to the hyoid and the other muscles in that anterior neck, and how that can need to be addressed if you're trying to correct that posture.
Mm-hmm.
Sure, and more on fascia too.
Well, yeah, because like I know we all work together with a lot of patients undergoing tongue tie release. And Dr. Dave, how do you see changes in people's body posture, just any changes from a PT standpoint when you're working with patients pre and post lingual frenectomy?
Yeah. So a lot of times those changes can be pretty quick initially, right off the bat. A lot of patients can return following, their frenectomy or frenuloplasty, and they immediately start feeling a little bit better. Now, one thing that we do need to also be aware of is that just because they've had the tongue released or lip ties released doesn't necessarily mean that their body totally knows how to now all of a sudden move into different directions. So initially there's like oh man, things are now loose. But then the body also is like, well, how do I use this newfound motion before it sort of goes back into old patterns and habits? And so that's where it's really important right after to then now take all of this sort of newfound motion that they have, not just in their tongue, but actually, believe it or not, all the way down. There's, like Dr. Andy has said, there's fascial connections from the tongue all the way down and into the feet and the toes. And so now for us as physical therapists, now we get really the exciting part of taking something that has moved a certain way and being able to say, hey, no, it's okay. Let me nudge you a little bit. Let's move this way now, and let's get that reciprocal motion. You didn't know how to move this way. Now let's show you and teach you how to move that way. And that's really the exciting part, is they get this usually improvement right away, but then you get to make the long-term changes right after, which is really what we're going for. the short-term effects are great in terms of reducing of that tension, but the long-term success is really what we're going after. And so that's exciting to see after.
Yeah, and you guys all chime in about like tongue tie because we know it's such a common thing in the myofunctional therapy patients. I know like we always talk on the side like, oh my gosh, there seems to be a correlation between like Dr. Randy's like noticing a lot of patients who have scoliosis. They seem to have that like restricted lingual frenum or other things. Can you talk about that a little bit, Dr. Randy?
Yeah, so I think there's some supportive research out there now with the connection between scoliosis and having the lingual frenum restricted, so the tissue under the tongue being correlating with that scoliosis. It's a midline deformity. Again, just thinking about the anatomy connections that we already talked about. And it's interesting, again, now that I know what I know, I have also patients that like I see for scoliosis that will always, kind of trigger my brain like, I wonder if that tongue has the full mobility or full function. And sometimes it's not like a obvious, and what I'm obviously learning from you guys is that it's not like a clear, obvious, like your tongue looks restricted. So it always still comes down to the function and how that tongue is doing the job that it should do. But yeah, I definitely think there's a correlation there. There's some supportive information for that. I even think, sometimes down all the way down into the foot, like some patients that I'll see with plantar fasciitis or, which is a blanket term, and maybe it's truly like shin splints or posterior tib tendinosis and some of the other things that pop up frequently that are a part of that connective fascial line to the tongue. They always trigger my brain to also want to know more if they are a PT patient, not necessarily coming already to us for myofunctional therapy, which has been great because we've been able to, now I'm also able to, I'm treating even a mom that's talking to me about their kid. And I'm like, ooh, actually, have you crossed this bridge yet? No. And so PT patients that are there for other things end up being myofunctional therapy patients and then vice versa. So the blend is really, it's hard to now think of like, what would I do if you weren't doing both of those things, or those people weren't getting both of those things? You're just missing parts of the puzzle. Did that answer your question?
Oh yeah. I mean, it's funny because it's almost like when you see these things, you're like, oh my gosh, how can other people not see this? And how are they functioning not knowing this? Like, what do you think, Dr. Kale? Like, sometimes you're missing things when you're treating patients, but you don't understand this component. It's like a knowledge, don't you think most physical therapists should have?
Yeah, I think it's a shame because you get out of PT school, you're like, okay, I know my stuff, and then you'll maybe do like a specialty, like a residency, or you'll go to postgraduate program, and then you feel really confident. You're like, man, I really know my stuff, and then you start learning more and more, and you start realizing, man, at this point, like what I thought I knew, there's so much more to it. So the more I learn, the less I feel that I know. So like Dr. Randy's saying, you go through this process and you're like, oh my God, I have patients. I wish I knew this back then because I could have helped her or him in a much better way. So I feel like, once you get into the deeper layers of, there's more underlying issues, that it's not just a musculoskeletal orthopedic issue. It opens your eyes. You're like, oh my God, you can't ignore it anymore. And we don't teach this in school. And we really should be, especially in the PT field. It's sort of coming into it, trickling in, but it's not there yet. So I feel like once we do this, even if a PT can recognize it and send out to somebody who's better, that's great. But we've missed it all these years. So I'm just so excited that we're able to catch these things and send people the right people and help in any way we can, because I feel like we're getting so many people better that we couldn't in the past.
And there's so many people I refer out to you guys as PTs who are those like females with the upper airway resistance syndrome. Dr. Dave, you get a lot of these referrals where there's fibromyalgia, whole body pain, headaches, thoracic outlet syndrome, all these issues, jaw issues. Can you talk a little bit about how you work with TMJ issues or the these patients, I have a lot going on, and there's maybe an underlying sleep disorder that's contributing.
Oh,
They tend to be
yeah,
the ones that
absolutely.
love to see you multiple times a week because they feel so good. They're kind of like
Yes.
addicted to PT because it helps so much.
Yeah, yeah, and especially when we're talking about, let's just take, TMD, and start with that. A lot of times, you got to treat the biopsychosocial side of things. What we've learned now is TMJ pain is not just because of a joint. There's stress that involves bruxism, there's sleep apnea issues, upper airway resistance syndrome. And so there's all these different things. And to kind of circle back to what Dr. Kale said earlier, when we're talking about cervicogenic headaches and headaches that start at the top of our neck and the base of our skull, well, guess what? They share the same connections as the trigeminal nerve. So, well, guess what? Now all of a sudden, we got to take that into consideration as well. And when we're talking about TMD, well, the C1 and C2 joint, the very first two bones of our neck, are actually in line with that TMJ. So guess what? They play off of each other a lot. And so when we're talking about TMD, there's so much to it. It's not only just like a joint in a muscle. You have to treat all of these different things. And the airway and sleep component is a huge part of it, especially for these patients that are not getting into the deeper stages of sleep and the REM sleep. They're continuing to be anxious, and they're not getting the body healing and the mind healing that they need. And so it can maybe start as a TMD, and now all of a sudden, before you know it, you have the fibromyalgia, you have more of the systemic inflammatory issues. And a lot of times it's because they're not getting this sleep that they need because they don't have the open airway while they're sleeping. And it just feeds in on itself. And it's just this vicious cycle. And so that's one of the things you got to look at is you got to look at the airway to really take care of the person as a whole. So that's why this is all really exciting, frankly, to all of us.
I know. And I think like now more than ever, most of our referrals, I always talk about the three systems: medical, dental, myofunctional. You guys are helping with the medical component, with the musculoskeletal system. But I feel like a majority, almost all of our referrals, we refer to a sleep doctor, and we refer to some sort of airway orthodontics if they don't already have that going on. Like, we don't just treat in isolation, right? You're not just treating that TMD patient for years and years because there's these other components, right? Whereas maybe in the past, they like coming, they feel better, and they just keep coming. It's like we do kind of push them, like, go get this airway thing resolved, right? Do you guys see that a lot?
Yeah, I think so. Sometimes they can, especially some of these people have already have so many diagnoses. Often they'll be like, "Oh, now you're talking about my tongue and my head now," and like it can sometimes be a little overwhelming. But I also find that although potentially overwhelming, it's empowering to the patient that it's a solution or an answer of how that could be the root cause. And if you're not sleeping well and your tongue isn't resting where it should and falling in your airway, that it could potentially cause your digestive issues and your pain issues and your arthritises and all the things that come from not letting the body get the rest it needs to repair and to restore itself for the next day. And so I find that like really being able to get the people that education of that it could answer a lot of your whys, even though it seems like big steps, really helps them, because it's not here's another diagnosis or a medication or some of the other things that we just see they've already gone through. It's really giving them like this could be a solution to all the other things, and it could take time to get there. It's not a quick and a fast and an easy one. But at least it's explaining something they usually have not heard before. And I think that as a clinician, it feels really good to have that information. And I think for patients, it's also like, oh, okay, there is something I can do about these other things. versus just list them off when I go somewhere. I'm like, and I have, that's because of my chronic fatigue, or that's because of my fibromyalgia. So it helps them hopefully just get a little bit more control of not having to use those diagnoses and being like, I have a solution.
I think one really important thing that we always ask is this problem going to be fixed by PT, right? Like, how do we know if physical therapy is actually helping, or are we missing something? And the way we try to teach our therapists is we try to focus on, you can make an impact on a patient. So a patient can come in with a cervicogenic headache, and you can do treatment of the top few cervical vertebra. You can do trigger points, fascial work, and all of a sudden, like, oh my God, I feel so much better. And then what happens is that lasts for a few days. Well, you did great. You reset something, right? You reset muscle tone. You inhibited a pain pattern, and they feel better. So the question is, okay, after you get this reset, now you have to restore the normal ability, and you have to re-educate the muscles to keep them in this correct position. Now, this process of that entire, process of resetting, restoring, and re-educating, that should take maybe weeks, okay? If the patient's not seeing consistent improvement, and instead what will happen is, take the headache patient, they'll come in, they'll feel great after their treatment, and then 2 days later comes back. And then they'll feel great after treatment, and 2 days later they'll come back. Well, they're going to keep coming in because they just are so desperate to feel better. But if it keeps happening, this cycle, and you can't break that cycle, you're missing something. And we have to recognize as practitioners, we don't have all the answers. We're missing something. So somebody consistently has an up and down and doesn't get this consistent curve, even if it's like this, you're missing a component. One of those components could be sleep breathing disorder, right? So that could be what it is. So if you're not getting your patient better consistently, and you're not finding this overall improvement over time and doing those things, there's probably something we're missing. And if we recognize that, we can help the patient get to the next level.
And sometimes the next level, I feel like we share a lot of patients that might be undergoing more rigorous orthodontic treatment or jaw surgery. And I see you PTs are like, they're supporting them with the whole prehabilitation and rehabilitation. I don't know if anybody has a patient right now who's kind of planning for a jaw surgery or something intense like that they want to talk about a little bit of that process.
I don't have any current ones right now, but I've treated some post the surgery, and they almost always have immediate changes. Obviously, it's intense, and their jaws wired shut, and you're not getting a whole lot out of it. But there's always immediate improvements in whether it's neck tension, or often if it's to that severity that the jaw's been needed to be moved forward. They immediately feel like they can breathe better. And that's a pretty common thing I'll hear after the tongue release as well, is, the tension just goes away, or I immediately felt like I could breathe better, which is not always the same response for everyone, but definitely very, very common. But that's another challenge too, is, if people end up on that, like you could be on the end of the spectrum where the in solution is a pretty aggressive procedure. It can be hard to hear, but also it's, if it answers a lot of those questions, people are willing to go down that pathway to get the relief that they're looking for, or have been, working on for 20 plus years and seen so many different people and so many different practitioners. And we'll see that a lot too. They're not all necessarily communicating. And I feel like that's what's been so great about kind of coming to this airway from this airway perspective is, we kind of call it like we need an airway ortho and an airway dentist and an airway ENT, which you'd think all of them would be speaking that same language, but it's not. It's the same as I didn't know what I didn't know until I knew it. And so it's been really helpful to have a team that's speaking that same language, so you can be confident in helping these clients get to the right people. Otherwise, they very easily end up going somewhere and they're like, "Oh, have mild sleep apnea." Like, what? None of that's good. What does that even mean? Like, mild sleep apnea. Like, it's still, and that'll be like you have it and nothing's done about it. Like, you could call it mild sleep apnea, but there should be something being done about it. So,
yeah. One of the things that would be interesting to talk a little bit about. Maybe Dr. Kill can talk about referred pain. One of the things I noticed, and Dr. Dave can chime in too, because when I was going to PT and I was having headache issues, little did I know my SCM was triggering my headache. And Dr. Dave was like pressing or squeezing on the sternocleidomastoid muscle. And I was like, oh my God, it's shooting that pain in my head. So I know, Dr. Kill, you talked a little bit about that, but can you talk more about like referred pain and especially SCM? Because I feel like that's a problem for a lot of people with posture.
So sometimes what we have is people call them trigger points. Referred pain is essentially anytime you have pain that is coming from one area, but you feel it somewhere else. It doesn't mean that if you push here, you feel pain running from here over to there, right? Or wherever it goes. It means that you push here and all of a sudden you feel the pain somewhere else. It could run, but it doesn't have to. And there's latent trigger points and active trigger points. And essentially, sometimes they're always on, whether you're pushing them on them or not. And when they're on, you're feeling that discomfort. Or a latent trigger point is when you push it, you activate it, and then you feel the referred symptoms. So SCM is a good one. I mean, we have for headaches, you have, the suboccipital muscles, the capitis muscles really up high, even upper trap. But SCM is a good one. So if you want to find your SCM, if everybody who's listening wants to try this, all you need to do is turn to one direction. So in my case, if you turn left as far as you can, and then you side bend your right ear to your right shoulder, and you'll see this muscle. You'd feel this big muscle popping out. There's 2 bands of SCM. It's right there, right? So that's your sternocleidomastoid, okay? So the sternocleidomastoid has 3 trigger points. It has like an upper, a middle, and a lower. So you don't know exactly where it is, but if you were to feel it, say, oh, there's my SCM. I can feel you can almost grab it, and it's like a piece of rope. And if you put pressure on it and hold it, and give it a few seconds, and you might say all of a sudden, oh, I'm starting to feel headaches through the headache symptoms or head pain, even that back across behind the ear. So if you find these points and you hold them, you might notice like, oh, there's my headache. And the idea with trigger points is you hold that point until that pressure decreases. And when I suggest holding a trigger point, your pain level or tension or pressure level should be 5 or under. Remember we talked about the sympathetic and parasympathetic. If you're pushing and feeling, I need to feel this, those type A personalities usually want to push like a 9. Like, oh, that's so good. And that's not good because you're essentially, you're upregulating your sympathetic nervous system. Nothing's going to calm down. It is not going to help. So better's not, no pain, no gain doesn't work. Stronger is not better. So you find a point, I recommend about 5 out of 10 of discomfort at max, and maintain that pressure until you feel that discomfort that's referring to slowly go away, okay? And as that relaxes, I would also do your diaphragmatic breathing. I try to relax, be in a good position, and it should slowly sort of melt away under your finger. And that could actually reduce your headache symptoms if it's coming from a trigger point.
How do you find where it's coming from? Is that what you do in PT then? You would find that like a person couldn't find it on their own?
So it's a lot easier for us to do it because this is what we do. We're manual therapists. We use our hands for everything. So the idea is for me, if I were at home and I wasn't a physical therapist, I don't know the anatomy, what you want to do is you want to contract the muscle so you can find it. So in order to contract it, you would turn one way and side bend the other. So for example, turn left, side bend right. That's your SCM. So now you can feel where it is. Now you can relax the muscle a little bit and put pressure through that muscle. Right? And you might find a spot like, ooh, that's really uncomfortable and it's reproducing some of my pain. That's how you find it. Now, this might be going a little too deep. I might be going a little too far here. But why would one muscle versus another muscle, the same muscle on both sides, why would one reproduce headaches, not the other? If you have a muscle that's on all the time, okay? So let's just make it really easy. Pretend it's your upper trap. Let's just say for some reason I'm up here on one side, and there's many reasons why this can happen. But let's just say I'm up here. Maybe it's because my posture. Maybe it's my position at work. Maybe I'm on a computer and I'm always turned this way, and I'm always up here. What that muscle?
It's like carrying a bag on that side.
The old purse syndrome. So picture yourself always having this muscle on. So now we're taking a muscle and we're changing its action, what it's meant to do. It's not meant to be on all the time. It's meant to, because these are phasic muscles, not tonic muscles. They're meant to turn on and turn off. If you have a muscle that's on all the time, so if your posture like this, you're here, these muscles are on all the time, and they shouldn't be, their tone changes. So this is hypertonicity. So you have a muscle that's always on, not meant to be on. Those muscles then can cause referred pain. So if you look at somebody, you notice there's an asymmetry because of something like position, posture, how they're sitting at work. Those muscles can actually cause a consistent referred pain pattern, and it won't change. I can dig in that muscle all day long. It'll feel better today. When you go back to that position tomorrow and do the same thing over and over again, it's going to come back again. So again, it's finding the underlying reason, right? If it's an airway issue, and that's why these muscles, the suboccipitals are tightening up because you're always back here and they're always tight, then me fixing those muscles and getting rid of the trigger points and helping the headaches is not going to fix it unless we fix the airway so they can be here. And now the muscles are at their normal resting length, their resting tension. Okay, so that's the primary fix. The big picture fix is find the underlying reason why they're in the position. Manual therapy helps temporarily, but change that mechanism. What is causing that irritation? Change that. Normalize tone in all different ways. And like we talked about, the PRI method is a great way. And that will give you the benefits long term.
I have a tone question. I've got to chime in with this question because I've had people ask, okay, you rehabilitate the oral muscular system. You get the tongue resting up on the palate, lips closed when the person's sleeping or when the person's awake. But when they're sleeping, muscle tone drops, tongue drops. How can you train a person to keep their tongue up while they're sleeping? Dr. Kale, tell me about muscle tone and resting tone and sleep. And I will just record that and play that for any doubters. Okay.
So I think it's important just to understand the physiology a little bit. So there's two different types of muscle tone. We have muscles that are tonic and muscles that are phasic, and then we have a combination of both, right? So you can have, for example, the rotator cuff muscles in the shoulder, the multifidus, the muscles in your spine. These muscles are tonic, more tonic muscle, which means that their job is to stabilize, is to be on all the time. When you train a tonic muscle with high endurance exercises, that even increases their tone more, and it stays on. If you take a muscle more like the bicep, right, and you train that muscle, that's more of a phasic muscle. It's meant to turn off and turn on, turn off and turn on. So with the tongue, there is a high propensity of tonic muscle fibers, and when you have tonic muscle fibers, when you train them, the muscle tone stays. So for example, if your rotator cuff wasn't a tonic muscle, at night when you go to sleep, your muscle, your shoulder would literally dislocate, right? You would fall out of socket. So if you see a patient with a stroke, sometimes you'll see they have this poor shoulders hanging out of the socket. Why is that? Because now you affected the neurological tone. You affected the tone of the rotator cuff, so it no longer can do its job. The only thing holding it there is the ligamentous and capsular structures. So, going back to the tongue, since it has tonic fibers, if you train it, the tone will stay. Now, it has to be consistent exercise, and the dosing has to be correct for that person, but resting tone is always there with tonic muscles. The tongue is no different. So if you train the tongue properly, even when you're sleeping, that tongue will stay where it's supposed to be.
That's good. And that's kind of what I've explained to patients, or, maybe if there's a doubtful physician or something, where I might say that we're not floppy when we're asleep, even though our muscles are in their lowest state of tone, we still maintain a resting tone in the muscles, and we are increasing the resting tone with the lips and the tongue to help the tongue stay up while sleeping. Okay, that's great. Couple questions kind of as we're wrapping this up, and if we left anything out or something else you guys want to say, definitely chime in. But I'm just thinking, like, if you each could say or think of these two things. So, like, given your understanding of now airway and myofunctional disorders, what's one thing that you think all physical therapists should know? Maybe we'll start with that. So colleagues, people you work with on your team who might not be aware of this, or other physical therapists, like what's something they should know?
I think one of the easier avenues to go with is just bringing their attention to whether they breathe through their nose or their mouth during the day. There's obviously a lot of other tools we use to get them aware of what they're doing at night, but that can be hard because their age or environment, and we don't know what we're doing while we're sleeping. So just getting them aware of that, like if, how do you breathe? Do you breathe through your mouth? And what do you do when you're playing sports, or what do you do when you're sitting at your desk? Because that can already give you some information if they're like, oh, you know what, now that I pay attention to it, my mouth is open, or I didn't realize it, but I am breathing through my mouth and not my nose. And that already sometimes gives some information as to like, okay, then if your lips are open, your tongue's likely down. It's going to be really hard for the tongue to stay where it needs to be and be in proper oral rest posture if your lips are open. So that can sometimes just help open the door if they're like here just for PT and not aware of that. If they're coming already from myo, I think the biggest thing that I educate on is just getting them aware of their entire body system and how it's stacked up with gravity. Gravity's always there. I always explain that muscle is attached to certain places to function a certain way. That length tension relationship is really important, like a bridge. If that position changes, muscles are going to be turned on just because of the position that you're in and gravity's pulling on you. So I always go through what I call just stacking your blocks, and go from the feet through the knees to the pelvis to the rib cage. And everybody's blocks are different. So we're not trying to say everybody should have this same posture. We're trying to help them understand how to align themselves. And then that helps them sometimes recognize where they have been compensating once you bring that awareness. As simple as, okay, get on our 2 feet. Do you feel equal weight on the right and the left? And often it's like, no, I tend to feel more on my right. And now I'm aware of that. And sometimes people have no awareness, and that also gives me more information as to like, okay, what is our toolbox going to look like? Because they've maybe been in this compensation or dysfunctional for so long that they just have really poor information coming in through their sensory systems. So I try to just make that a part of everything, is stacking the blocks and making sure they're starting to understand what position they're in and how that's going to affect the oral rest posture we're working on. And why that is all connected.
Mm-hmm. Yep. Yeah. For patients. Go ahead.
Yeah, I can. I'll piggyback off of Dr. Randy and Dr. Kale there on their past couple points here, talking about tone and airway and rest posture of the tongue. Just having physical therapists just understand how we should be utilizing the diaphragm effectively. Because if we're not diaphragmatic breathing appropriately and getting that true lumbopelvic kind of stabilization, intra-abdominal pressure, then all of a sudden we start chest breathing, we start getting into that high sympathetic tone. And really all of this deep line fascia, we call it, where the tongue is connected to the abdominal muscles and the diaphragm and the adductor muscles all the way down to the feet. Just really understanding that if we can just get the patient to start by diaphragmatic breathing appropriately, then we're also going to change tone in a good way. Those phasic muscles that Dr. Kell mentioned, we're going to decrease the hypertonicity in those. And really the tonic stabilizers, such as tongue musculature, deep neck flexor musculature, that tone will increase. So guess what? Now we can get the patient to actually rest their tongue up on the palate like we want, all because we started changing the understanding of diaphragmatic breathing.
Dr. Kell, what do you think all PTs should know, given all this
air? Go last.
It has to be something different than
everything. I mean, these two therapists are so great, and I feel so lucky working with them. But on the other side, I
want to say what Dave said. I take Dave's answer.
So one thing I think is from a therapy perspective, sometimes we get patients that were like, oh no, this is one of those super anxious, They have sort of everything, like Dr. Randy mentioned. They have systemic arthritis and other autoimmune issues and all these things. Like, oh, this is a headache patient. I mean, not literally, well, they could be a headache patient also, but it's a headache for the PT. And we're like, oh, where do we start? Like, oh my God, like, I don't even know where to start with this patient, because they have physical issues, they have emotional issues, they have anxiety, and they have all these other things. And I think that if we can step back as therapists and say, okay, we do have all these things, but what is the one component we definitely can start with that can change all of that? And I think that if we look at the sympathetic nervous system and trying to downregulate that, we can make big changes right away. So as everything we're talking about, looking at diaphragm, looking at positioning, looking at sleep breathing. So if a patient, like Dr. Randy mentioned, if a patient is not getting good restorative deep sleep and having fragmented sleep, even if a sleep study shows that it's a mild sleep apnea case, we know it depends on the sleep study, how they're reading it, whether the different classifications, what will show up. So we can't trust that it's mild means not a big deal. It is a big deal. So if we recognize that these patients, there is a sleep disorder, and we can help them make any changes on that front, then we can actually automatically calm down their sympathetic nervous system. That could then in turn help with a lot of their musculoskeletal conditions. Like Dr. Randy mentioned, that patient was like, hey, I love you, but I'm out of here. I have my CPAP. If we could just as therapists just sort of open our eyes a little bit and say there's another part here that we have to be aware of. And if we could focus on the breathing, like everything we've talked about, and give that component, some of those very difficult patients will be way less difficult to treat, and we can help them. And if we think about that deep restorative sleep, the lymphatic system is now during that process of healing. Musculoskeletal issues need that deep sleep to heal. So even if we're purely talking about an athlete that comes in with a hamstring strain that does not go away, and we've treated all those things, we think all the components, from here down to the foot, and we don't look at the sleep breathing, it might be that their issue is they're not getting restorative sleep and their tissue isn't healing well. Maybe they're not getting nutrition. There's many components, but we can't ignore those components. So I think the more we look at this holistically at all the different systems, the better outcomes we'll get.
Yeah, I think that's great. And a lot of this airway dysfunction is evident by looking in the mouth, looking in the oral cavity, right? There's nearly always an anatomical component. So it's almost easier to start to get suspicious when you see tongue scalloping, mouth breathing, plus that forward head posture, narrow palate, crowded teeth. What is orthodontic history? And we ask so many questions that I feel like we're just picking these airway sleep people like crazy. We're like, oh my gosh, here's another. How do we talk about this? So it's just all too common, unfortunately. But I feel like this team approach is so necessary. And I feel like it's so important for everyone to have a great PT on their team that they can refer to and work with. And I feel like it's so important for all PTs to have this understanding and knowledge, even if it's just basic level, to know, oh my gosh, that patient with that posture, it might not be just a genetic issue. They're posturing that way for another reason, or that woman who comes in with chronic headaches, blah, blah, there's something else going on. So I feel like to sum up all this great conversation of what we all just talked about, what you all really educated everyone on, is the body is connected, right? It's connected head to toes, tongue to toes, it's all connected. When we have dysfunctional breathing, that triggers sympathetic nervous system arousal, which triggers more dysfunctional breathing and less healing, right? So when we get that good diaphragmatic breathing, you're triggering parasympathetic nervous system, rest, digest, relax, and that can promote good healing. These fixes aren't fast necessarily if there's these underlying airway components. And headaches can also be related to poor posture, which could also be that underlying airway issue. So it's just all connected. And I don't know if there's any other summary points that you guys feel like I'm missing. Anything else?
I think that's good.
You did great.
Yeah.
I
I
got
feel
it
like
all.
it's so great. I mean, I don't know where I was a few years ago when I was not working with you all in this capacity, because it's only gotten better. This holistic approach to treatment, I feel like the patients are doing so much better, and they were doing really well before with just what we were doing. And now it's like a whole other avenue of whole body work that's getting people to another level of healing. So everybody find a good PT for your team. If anybody who's listening has questions, we'll send email information. You can contact us and we can help guide. All right. So thank you everybody for listening and being here. I really appreciate all your help and your airway interest. Thank you guys.